Hi, my name is Karen Jones, and I'm Executive Director of the Waha Warriors. Today, during this webinar, we are going to be answering some questions. Some of them came from Facebook polls that I did a while back, and some of them came from another Facebook post that I did called Ask a Hematologist. So today we're going to answer many of them, maybe not all of them, but we'll have a great start. This question is from Eric Alderman. He is a Waha Warriors Patient Advisory Board member.
Question comes from Jackie Hall. How can we find clinical trials available for WAHA?
I get to answer Eric's question about where to find clinical trials, and that is online. I'm going to share my screen with you so that you can see how we do it. So you go to clinicaltrials.gov and you'll come to this page. You put in your warm autoimmune hemolytic anemia, hit search, and they will all come up. And you can see them here. You can see the status, if they're still recruiting, if they've been withdrawn or they are finished. And you can see the sponsors. When you click on them to get more information, you'll be able to see the criteria to be involved in the clinical trial and who to contact to find more information. Imola Morez asked the next question, and she is on our patient advisory board.
My first question is, what are the treatment options if prednisone does not work, or if I don't want to take it permanently? And what if nothing works, not even prednisone?
Hi, my name is Dr. Irina Murakovska, and today I'll be answering a few questions that you may have about autoimmune hemolytic anemia as well as COVID-19 infection. So in people who received prednisolone and it didn't work initially, or who experience a relapse on prednisolone treatment, rituximab remains the next line of therapy. And again, remissions are seen in about 80% of people, irrespective of your prior use of the rituximab and your prior response. Again, even with use of the rituximab, long-term remissions, meaning more than a year or 2 years, are still seen in only 25 to 50% of people. And subsequent treatments that can be tried in people who are not responding to rituximab could be a splenectomy, so removing one spleen, because that's the place where the red blood cells are being destroyed. And it can be particularly effective in people who've been previously treated with rituximab. And then other immunosuppressive medications, such as azathioprine or cyclosporin or Cellcept or cyclophosphamide, are options which we use usually what we call in third line and later after the steroids and rituximab have not worked, or if we are unable to taper the prednisolone to a tolerable dose, which is generally less than 20 milligrams per day. If none of these treatments work, clinical trial is a great option for patients, and it's never a good time to be diagnosed with any disease, but this is probably a better time to have this diagnosis than, let's say, 10 years ago when we had very few treatment options available. There are multiple clinical trials and multiple agents in development, fostamatinib and parsaclisib and nipocalimab, just to mention a few. And a lot of these drugs are in later stages of the development, and hopefully many of them will be available soon. In addition, some chemotherapies, such as bortezomib, has been shown to be effective in patients with warm autoimmune hemolytic anemia. These therapies target what we call plasma cells. So those are the cells that actually make the antibodies. And again, like splenectomy, they may be more effective in people who've previously received rituximab and have relapsed after rituximab or have not responded to that.
And now Dr. Ponch, Medical Board Advisor, gives us more information on that same topic from the back seat of a taxi.
I have, depending on severity, if they absolutely need transfusions, then we know that they are in the severe category. And in that case, I not only initiate steroids, but I also think about initiating rituximab. I specifically scan these patients, their CT, chest, abdomen, pelvis, to make sure there's no concomitant secondary causes like lymphomas. And then, as you know, there is a big paucity of data here, but these are certainly two therapies that are known to have worked. And the first dose of rituximab, for instance, there is data, at least in severe disease, that the sooner you administer it, the better. So that's certainly something that I would consider, at least the first dose, and then can follow up and do additional doses to complete the 4-dose regimen as outpatients. In addition to that, I make sure to have them on folic acid, 5 milligrams, 5 milligrams. So the typical dose is about 1 milligram, but because there is significant hemolysis, I make sure that they are also on folic acid supplementation to keep up with the ongoing hemolysis. These patients are typically not iron deficient, but I also check for that. And as you know, transfusions, I transfuse very gingerly, but obviously if they need a transfusion, they do need a transfusion. But it's a constant conversation with the blood bank to make sure that they get best matched units, and if necessary, phenotypically matched units if their transfusion profile or antibody screens are unable to be, are uninterpretable. In addition, next line of therapies, IVIG may not be as useful, but I have certainly administered it in some patients. Then you go on to therapies which have less direct evidence for response or efficacy, but I have used Cytoxan in the past, occasionally used MMF for chronic hemolysis, and other second-line agents. And then importantly, I also make sure that once the patients do respond, I try to taper them off very slowly off of steroids. Splenectomy is also been performed. I have to say it certainly is more commonly performed than it is for ITP these days. That said, splenectomy comes with its own risks in terms of thromboembolism and risk of infections and so forth, requiring vaccinations prior to performing splenectomies, but may end up being required in certain patients. More recently, there are other avenues being explored. As you know, fostamatinib has been studied in WAHA. Unfortunately, the study that was completed most recently did not show a significant benefit or efficacy, but there have been suggestions that data were, there were big data differences across various institutions. And so that may be one reason. Certainly something that I have resorted to in the event that the patients have failed several of the other therapies that I just outlined. So one of the things I also wanted to add, steroid therapy is not without risks, right? I think it's important always to ensure that patients who are on steroid therapies ought to be considered for additional therapies like PJP pneumonia prophylaxis or vitamin D supplementation. If they've been on extended time periods of steroids, chronic steroids, you also need to think about bone density scans and risk of osteoporosis. You want to be making sure that they have adequate supplementation of calcium and vitamin D for those reasons. And, antacids or proton pump inhibitors while they are on steroids. And so I have a template, for instance, that I use automatically when patients are on steroids, anything more than 20 milligrams of prednisone equivalent, I make sure that they are automatically receive all of these other ancillary therapies. And also their blood glucose has to be monitored, and they, you have to keep an eye to make sure that they don't get hypertensive, ask them about insomnia. There are ways to manage insomnia and other, you know, psychological and psychiatric side effects that steroids may cause, especially at high doses, and especially because you end up tapering them much more slowly than, say, you would for ITP.
Okay, well, that's good to know. Our patients do ask about that quite often.
Yeah.
Mhm.
And of course, I would strongly recommend having steroids on board for as lesser time as possible, and start thinking about steroid sparing therapies.
Next question is, what supplements and vitamins can help with managing the symptoms of WAHA? This question comes from Samantha Lee and Melissa Dunlap.
You know, in this case, besides taking, like I said, folic acid, which basically is the substrate for more red cell formation and more active red cell formation, because you're hemolyzing at such a rapid pace. And, you know, normally about 1 milligram daily is recommended. In active hemolysis, we recommend as high as 5 milligrams daily. Besides this, there is really no other good, you know, vitamin or supplement that I know of. And, you know, certainly patients may feel strongly about one particular dietary, you know, item versus another. And I have had patients, for instance, with ITP say, you know, ginger makes it worse, or garlic makes it better, and so forth, or vice versa. The problem is that the active ingredient in all of these food substances is just, there's just so many ingredients that it's really hard to tease apart what may increase or decrease hemoglobin or cell counts, or impact these counts negatively, for instance. So unless you consume garlic in boatloads of quantities, there's no way for us to, you know, even do a clinical trial on these sorts of questions, unfortunately. So I would say the answer is we don't know. What I do encourage patients to do is, if they do decide to take specific vitamins or supplements or something, try to pick one supplement or one agent at a time and take it for an extended period of time and see if it helps or harms you. You know, if you take a bottle with a concoction of different things, you really don't know what helped or what harmed you, you know. And same thing with same thing with you know, dietary changes. Make one change at a time and see if that helps or doesn't really help you. I would say always make sure to tell your physician if you're taking any particular supplements or such, so they can document it, as you may be on concomitant you know, medical therapies that they would prescribe. And then, you know, you want to make sure there's no drug interactions and so forth, because some of these can, you know, are you know, enzyme activators, inhibitors, and so forth. So you want to be careful about what you take.
Next, Azreen Iqbal will ask our next question. She's a patient advisor.
The question is from Ms. Larissa Sepetic-Frazier. How many COVID-19 vaccinations are recommended for people with WAHA since they are immunocompromised? Which ones would you recommend as the safest?
So the first question that we have is, how many COVID-19 vaccinations are recommended for people with WAHA since we are immunocompromised? And which brands are the safest? So I guess the first issue is, what is considered to be immunocompromised, or who is considered to be immunocompromised? So patients who are considered to be immunocompromised are patients with hematologic malignancies, such as leukemias, lymphomas, or multiple myeloma. Other patients with cancer who are undergoing chemotherapy, patients who underwent bone marrow transplant or transplant for hematopoietic malignancies, so hematopoietic stem cell transplant, or patients who are on immunosuppressive medications, for example, rituximab or cyclosporin or cyclophosphamide, which a lot of patients with autoimmune hemolytic anemia are. In addition, patients who are considered to have impaired splenic function, so either because the spleen is not functioning, or because it was removed, for example, as a treatment for warm autoimmune hemolytic anemia, are considered immunocompromised. So for immunocompromised patients, the recommendation is to have an additional dose of vaccination in the primary vaccine series. Basically, what that means is for mRNA vaccines, such as Moderna or Pfizer BioNTech, in addition to the 2 recommended vaccines in the primary series, the CDC is recommending a 3rd vaccine in the series to improve the vaccine response. So for example, for our patients who are being vaccinated with Moderna, the initial vaccine series would consist of 2 vaccines 4 weeks apart, and a 3rd vaccine is recommended at least 4 weeks after the 2nd vaccine. This is considered the primary vaccination series, and in addition to that, a booster is recommended. Since more recently we have a bivalent booster that addresses the new Omicron variants B.4, BA and BA.4 and BA.5, the new booster is recommended at this time for everybody who has not received it within the past 3 to 6 months. For patients who are initially vaccinated with Pfizer vaccines, the initial series consists of 2 vaccines 3 weeks apart, like for everyone else, plus an additional dose 4 weeks later for immunocompromised patients, as well as the booster. And again, bivalent booster is available for patients who are getting vaccinated with Pfizer. It is recommended to stay with the same vaccine in the initial series, unless it's prohibitive for any reason. But you can switch the type of vaccine when you're receiving a booster. More recently, a new vaccine was approved from a company called Novavax. It just became available in July. It is univalent, so it does not cover the new Omicron variants, and it's a conventional protein-based vaccine and may be more acceptable for people who feel uncomfortable with mRNA technology.
Next question is from Ms. Dottie Clark and Angel Asher. Where can they find mental health resources for WAHA?
If you're looking for mental health resources, you have a few options. The first is to just do a Google search and look for mental health resources near me, and it will list them usually on a Google Calendar, and you can see from there what your options are for near to your home. After that, if that isn't what you need, you can go to NAMI, and NAMI is the National Association of Mental Illness. You just Google them, and they have a number of options in every state. The third one is, though, if you are having an immediate mental health crisis, there is a nationwide mental health hotline. You dial 988. Next, we have Danae Chimmel. She is a member of our patient advisory board.
The chances of my WAHA returning after being in remission? And if so, what would be the first line of medication that would be given to me?
So the next question that we will address today is, what are the chances of warm autoimmune hemolytic anemia remaining in remission? So it's a complicated question. There's a lot of studies done that have somewhat different results. On average, about half of the people will remain in the remission, but it at least in part depends on the therapy that the patient receives. In the 2 main trials that compared use of the rituximab with use of corticosteroids, the patients who received corticosteroids alone, a year later, about 30 to 35% of patients remained in remission, compared to patients who received rituximab, where about a year later, 75% of patients remained in the remission, and 18 to 24 months later, that number was a little bit lower at 65 and 60% respectively. So that gets us to what would be the first line of treatment for a patient with warm autoimmune hemolytic anemia diagnosis. So the standard initial therapy, which is really based on our experience and not much on any randomized controlled clinical trials, that because they're so sparse, is therapy with corticosteroids. And we typically use prednisolone 1 to 2 milligrams per kilogram per day. So for an average person, that translates to about 100 milligrams of prednisone a day. We typically continue this therapy for about 2 to 3 weeks. And at that time, we would expect a response to treatment, which is achieved in about 80% of people. What do we mean by response to treatment? We would like the hemoglobin to be at least 10 or above. If this is achieved, we continue the prednisolone dose and taper the prednisone by about 10 milligrams a week until we get to a dose of about 20 milligrams, at which point the taper is slowing down, and we taper by about 2.5 milligrams every 2 weeks, but the individual schedules vary. So as a result, a lot of patients will remain on prednisolone for at least 4 to 6 months. And we actually know from the observational studies that a more faster taper can result in increased risk of relapse. So this is part of the reason why it takes so long to taper the prednisone. Based on the two studies, one was done in 2013 and one was done in 2017, looking into this addition of rituximab to prednisolone, as I've mentioned previously, these two studies showed that we do improve the risk, we do improve the chance of remission with the use of the rituximab from about 30% at a year. So we're talking about longer term remission here, to about 75% in a year, and 65% at 18 months and 60% at 2 years. So currently rituximab is recommended at least for people with severe autoimmune hemolytic anemia. And by severe, we define, we mean hemoglobin less than 7, low reticulocyte count, or for people who cannot tolerate this really prolonged steroid exposure. For example, people with diabetes or osteoporosis or immunocompromised in other ways. However, a lot of physicians would use rituximab, and some recommendations are, do use rituximab in first-line therapy, even in patients with milder disease, so non-severe disease.
Justin Morris asked the next question, and he is on our patient advisory board.
Explain the difference between primary and secondary WAHA.
The difference between primary and secondary WAHA is that in primary WAHA, it is unknown as to why you have it, idiopathic. In secondary WAHA, it is because there is an underlying condition that is causing your WAHA or linked to your WAHA, such as a lymphoma.
Where can I get more information about WAHA?
You can get more information about WAHA here at www.wahawarriors.com, or also on our private Facebook group. I'd like to thank you all for watching our webinar, Ask a Hematologist. As you can tell, there are lots of people involved in doing this, and I need to thank them all. So first and foremost, those of you who answered questions on our Facebook page, either in the Ask a Hematologist section or the polls that I posted, we really appreciate that kind of interaction from our warriors, as well as our medical board members. We have Dr. Arena and Dr. Ponch who answered questions for us, and our patient advisory board members, Eric Alderman, Justin Morris, Sean Powell, Azrina Iqbal, and Emily Morez. They're wonderful, and we couldn't do this without any of you. We also like to thank Novartis for sponsoring this webinar, as well as a fact sheet that we are currently preparing using this information. You'll be seeing that come out soon as well. I have to put a plug in for our annual meeting because it is March 24th through the 26th in New Orleans. It is the first time that the WAHA Warriors have ever been able to have an annual patient meeting that brings together patients, caregivers, researchers, hematologists, and all of our speakers as well. So please, if you've not registered, go to our website, www.wahawarriors.org. At the top, you'll see annual meeting. You can scroll through all of the details, the current draft agenda that's up, and then there is a registration form. Please, if you haven't registered yet, please do. If you have any questions whatsoever, you can send me an email at Karen@wahawarriors.org. And again, thank you so much.